but she did a phenomenal job raising awareness for brain aneurysm. September is Aneurysm Awareness Month. So we have here Dr. Johnson Foy that's going to tell us about what every single primary care physician should know about a brain aneurysm. Yeah. Thank you.
Good morning. Again, I'm Dr. Trishella Johnson Foy, family medicine at Baptist Primary Care, and I thank you guys for allowing me the opportunity to be here with you today. I know that many of you are beyond primary care, but hopefully this talk will allow you an opportunity to kind of know how to go back and engage with your other colleagues and those who you're trying to teach or train on this topic. So I have no disclosures other than that today is a day of engagement during Aneurysm Awareness Month. And so hopefully this talk will be engaging for you. The objectives are for us to kind of really define the condition and identify those different types of aneurysms, discuss the epidemiology, and then clarify risk factors, helping your primary care doctors really define signs and symptoms and determine what are the best diagnostic tests so that they may be able to understand management options and then help facilitate providing reassurance to patients who may be dealing with this. Now, this beautiful woman here, many of you may know, some may know her better though, as Daenerys Stormborn of House Targaryen, our great Khaleesi and mother of the dragons and the breaker of chains. However, she faced a different fight not long ago, where she actually at the age of 24 suffered from a subarachnoid hemorrhage during the first season of Game of Thrones. She had 2 aneurysms and 2 brain surgeries, which ultimately were 2 near-death experiences for her. Now, this great, beautiful beast is one that many have unfortunately tackled. Some, though, have not made it through. Some have fallen. Many faces that you've seen that you may not have known were actually affected by aneurysms, but that doesn't have to be the story of all. Now here locally, right around the corner, there's the park named after this woman, Miss Tilly Fowler, who was a up and coming politician who based here in Florida, but had made it to Washington. And in 2005, she died from a brain hemorrhage from an aneurysm. So there are many lives that are cut short. So this makes this an extremely important topic. About 1 in 50 Americans have a brain aneurysm that's unruptured. But 4 out of 10 of those people who will rupture will die as a result of it. So this makes this conversation extremely important. When you look at those numbers, that's really about 1 to 3% of our population. And breaking that down further, about 80 to 85% of these result in these non-traumatic subarachnoid hemorrhages. Autopsy studies show that the prevalence in the adult population may really be between about 1 to 5%, and there are some studies that actually show that this goes up to about 7%. And so it can be a little bit underestimated. The good news is 50 to 80% of aneurysms do not rupture during the course of a person's lifetime. So there is this great opportunity to live with this. And that is what primary care physicians need to convey to patients, that this does not mean that they have been given a death sentence. We need to help them understand that this is something that they can live with. Very specifically, though, this is one of those conditions that are more common in women, about 3:1 to 2 ratio of women to men. The problem with aneurysms and why today is important, why this day of engagement, this month of awareness is important, is because although you have 16 to 15 million people in the US having a brain aneurysm, 90% of them know little or nothing about it. So what are the facts? The risk of an aneurysm bursting is less than 1%, less than 0.5% throughout a person's lifetime. But if it does rupture, they cause the most debilitating strokes. But only 13% of strokes are caused by ruptured aneurysms. So what do we need to do then? We need to be able to understand what the risks are, what is the proper radiology to evaluate these aneurysms, when to refer, and more importantly, how to reassure. So before we get into that, I do like to take a step back for a moment and remind some of our generalists what the anatomy is. That blood flow to the brain is supplied by 4 major blood vessels that join together, forming the circle of Willis. You have the anterior and posterior cerebral artery, the internal carotid arteries, and your basilar artery. Now, what is an aneurysm though? The aneurysm is this weak area of the wall of the blood vessel that causes the blood vessel to either bulge or balloon out. It usually occurs in those areas of bifurcation or where there's a change in the vessel structures, things like AV malformations. Major structural changes in the arteries and hemodynamic mechanisms are what are believed to really be the major factors and forces in what leads to the development of aneurysms. Most people having them, though, will not have any symptoms throughout an aneurysm until it ruptures. And there are symptoms at that time that we want to make sure we pay attention to. And then the repair. What do we do about them when we find them? There are several different types of aneurysms, though. You have saccular, or those berry aneurysms that are quite often known. You'll hear people talking about berry aneurysms. You have fusiform and then dissecting. These are when the actual wall of the vessel are involved and you have a true outpouching or a true bulge of the wall. But there are also what we call pseudoaneurysms or false aneurysms, where there's no true bulging of the actual wall or adventitia of the vascular wall. Sacula aneurysms or berry aneurysms are the most common and are thought to be either degenerative or developmental. There are other potential sources or reasons for it that I will talk about a little bit later, but it's important to have the conversation about these because they're the most frequent cause of these clinically significant bleeds or ruptures. When we look at the circle of Willis and where they most often occur, it's about 40% in that anterior communicating artery, about 34 to 35% in the middle cerebral artery, and about 20% in that posterior communicating artery. But right there in that circle is where you're going to see most of these aneurysms be present and cause most of the problem. Right there in that central portion of our brain is where we have to worry the most about these saccular aneurysms. Now, there was a time when it was thought that these were mostly congenital in origin, but studies after studies have shown that there is really no great evidence that it's congenital or developmental, or an inherited weakness in the arterial wall, although there are some genetic conditions that are associated with an increased risk of developing these aneurysms. But when we look at what is truly leading to the development of these aneurysms, it's thought to be most likely related to the hemodynamic changes that cause vascular injury. So the occurrence, growth, thrombosis, and even rupture of these are usually explained more so by these abnormal hemodynamic shear stresses on the walls of these large arteries that are at these weak bifurcation points that are what put people at greatest risk for developing and rupturing aneurysms. Other causes would include trauma or infection or tumors. And then in this time of this epidemic that we live in, drug abuse. So looking at these patients who are currently increasing the use of opioids and heroin, this is when you have to also consider all of these as these great risk factors for the development and rupture of aneurysms and these other high flow states associated with AVMs and fistulas. Now, when we break it down, you have either inherited risk factors or acquired risk factors. Those inherited risk factors, a lot of times we think immediately of just 1 or 2 genetic conditions, but there are actually several that are associated with it that I'll get into the more important ones a little bit later. But if you want to refer back to this and really see what conditions put people at risk for the development of aneurysms, this list can be a bit helpful. Outside of the genetic conditions, you have just being born a woman. I've told you that there is an increased female to male ratio, and then family history of aneurysms that are an inherited risk. And I'm gonna go back for you real quick. I saw some other people. And the second screen, we're going to really talk more about those other inherited risks that we've got to pay a little bit more attention to. Now, acquired risks are things like advancing age, alcohol consumption, cigarette smoking, that illicit drug use, hypertension, and trauma and infection. Those are things that we have a little bit more control of. But it's important to help people understand that even though they have risk factors, this does not mean that they're absolutely going to develop an aneurysm. There are some people who have multiple risk factors and never develop an aneurysm. And most people who develop aneurysms actually don't show a lot of these risk factors at all. So knowing your risk can be helpful and important. So as their clinician, you need to make sure that you are risk stratifying them. But this is where the reassurance comes in, and this is where being diligent as doctors come in, is that we make sure that looking at the risk, but putting it not in a prescriptive matter where we just are saying this is what's going to happen to you, but helping people really kind of understand, just like you would do with any other disease or condition, what their risks are. Now, there have been some genetic testing that has been available to look at what people are going to be most likely to rupture. So there's one thing to have an aneurysm, but then what is your true risk of rupturing if you have it? And so there are some studies that look at the genetic makeup of some of these patients to clarify, is there something that is going to make a certain group of people more likely to rupture? So there has been some chromosomal associations that have been noted and found, but it's still not something that we can definitively put our fingers on. There are many studies that have been done on looking at what the natural history is, but we still don't know. So how do we stratify? How do we provide reassurance when we don't know? There is a way to look at a patient and give them a score, and this is called the phases risk score, where we look at a group of potential risk factors and determine the likelihood of rupture. Now, this you can see is a long list that I won't go into in detail, but what is more important is when you create a score, when they develop a score, the higher that score is, the more likely they are to rupture. So if you have someone who you know has an aneurysm, this is your way of walking them through what their potential risks are. So this phases risk score, and allowing this to guide your management with them and allowing them to be able to understand how diligent they should be with follow-up, what types of things should be done, when to refer. These are the things that allow us to kind of move forward. Now, there are going to be a certain subset of your population, certain patients that you really need to pay particular interest to, and those are people with polycystic kidney disease, AV malformations, and fibromuscular dysplasia. It hasn't been that long that we really begin to understand the risk of fibromuscular dysplasia, but we know now that there is definitely an increased risk of these patients being more likely to develop these aneurysms and have potential ruptures. Family history, however, studies show that it only predicts the likelihood of developing an aneurysm, but not necessarily the risk of rupture, which is again why we need to look at all of this information together to decide how we want to proceed. So then who needs to be screened? Who are the people that we really should be sending for scans? If there's a person who has 2 immediate relatives with intracranial aneurysms, then those are the patients that we need to send for scanning. There's a 4% risk if there is 1 family member, but then that increases to an 8 to 10% risk if a person has 2 or more family members. All patients who have polycystic kidney disease that are of autosomal dominant variant should be sent for screening and should be sent for evaluation because they are at a higher risk of development. But we live in a world now where, regardless of what the doctor says, patients have the ability to go and have genetic testing. And they go and they get these screenings. And the question is, what do we do with it? How do we help them through this? How do we help them understand what these genetic information means? So we have to, again, provide that reassurance and that confidence that although these tests are available, although these tests can be done, it does not really allow us to understand what your risk of rupture is going to be or your true risk of development. So just like with the rest of the conditions we're dealing with, people having this information available can sometimes complicate our lives as physicians, but we can use it to help them through what they may need for helping them understand their risk overall. There are some studies actually that show aspirin being something that when we think about subarachnoid hemorrhages and bleeds that we should stand down from. But for those of you who are neurovascular and in this conference likely have an understanding that there are some studies that show that the rupture risk is actually reduced in patients who take aspirin. And so there was a large meta-analysis done about 2 years ago that also spoke to this. And so what we don't completely understand is why that risk, and it's thought that it may be due to the anti-inflammatory properties of aspirin, but we're not sure. It's still something that you want to individualize when you talk to patients and really get clarity on what might be right for them instead of just blanketly putting everyone on it. So as primary care providers move through taking care of these patients, they want to be clear that they're making the right decision for that patient and not just what is new to do at this point. Looking at your patients is not just about what is internally going on inside them. We know that genetically there are going to be some groups, the same way we know women are more likely to have aneurysms. Black women are more likely to actually have ruptured aneurysms. So you want to make sure that you are being diligent and expressing to your women who are of African-American descent or African descent that they may have a higher likelihood of rupturing, so that follow-up is going to be one of those things that are important. Because if you remember, most people don't have symptoms. But when they do have symptoms and warning signs, we need to pay attention. We need to make sure that we are following the signs. So what are some of those things that you have to look out for? Well, if they're presenting with severe headaches, this would be something that you want to make sure you're doing your due diligence, looking for aneurysms. Seizures, light sensitivity, double vision or blurry vision, face pain that may be an unusual presentation, or if they're having small embolic strokes, you can have those coming from a thrombus in an aneurysm. Visual field defects that you don't necessarily have an explanation for is a reason for us to make sure we're looking for aneurysms. And then TIAs, a dilated pupil that is has all of a sudden developed that may be unexplained, maybe is a reason to go ahead and investigate. There are many misdiagnoses when it comes to ruptured aneurysms. People present to the emergency room, and unfortunately, oftentimes they are not scanned appropriately. So we want to make sure that as we're training our physicians and training our ER docs to know what things to pay attention to so that they scan the right people so that these patients don't end up dying from something that is presenting. We know that it's very important to diagnose these things as early as we can. So what studies should we be ordering? Well, CT angiogram, MRAs are the scans of choice when it comes to monitoring and evaluating for unruptured aneurysms. And I'm sorry, what is the gold standard is actually going to be angiography. But what is often easier and quicker to do in those moments are going to be your MRA or your CTA. So with the CT angiogram, it's very accurate, it's high resolution, and it has a sensitivity of about 97% or 77 to 97%, and a specificity of 87 to 100%. That sensitivity does drop when you have those smaller aneurysms, and smaller being less than 3 millimeters. You are limited in patients who have impaired renal function, so then you have to consider alternative ways of looking. The MRA also has great sensitivity of 70 to 99% and a specificity of 100% for aneurysms that are 3 millimeters or greater. But again, that sensitivity diminishes for those smaller aneurysms. Oftentimes, though, we don't have time to get the MRA right away, so it becomes important to do the test that is available so that you can do your monitoring. Now, a catheter angiography, whether it is with or without advanced 3D capability, is the gold standard. It's more expensive and a little more invasive. However, this is what is going to give you the greatest bang for your buck. This is where we make sure that we get into our great neurosurgeons who can really guide these patients and take care of these patients. And then this is handoff time. This is when the management is done. Initially, depending on the patient, conservative management, just like with most things, is oftentimes first and foremost. Those people who are in dire need will move beyond that, but patients who are usually over the age of 60 and have small aneurysms, except for those with a strong family history, are usually managed conservatively. But patients with aneurysms 7 to 12 millimeters diameter, that management again needs to be individualized. So looking at a patient and stratifying their risk, the likelihood of rupture, using those phases score, that will help you decide how to manage these patients. Now, this goes beyond primary care. So the most important part was 3 slides earlier, where we get them referred to the right people who will decide how to manage them. They will consider the proper interventions, and those interventions being either coiling or stenting with coiling or clipping these aneurysms. This is something that my neurosurgeons will decide for me. I don't have to make those big decisions. Primary care doctors don't have to, but what will happen is the patients will come back and ask their primary care doctor. My patients are very particular, and even though there are bigger brains in the rooms that talk to them and tell them this is what they're gonna do, they're gonna come back and say, well, Dr. Johnson, what do you think? And so you have to be prepared to make sure that you are adept with answering the questions and reassuring them that you put them in good hands and that the right management plan and the right strategy is being developed for them. But the biggest thing that we can do as doctors for our patients is provide this reassurance for them. We've talked about the overall potential risk of rupture being less than that 0.5%. So how do we allow people who might have heard of someone or who know someone that they died immediately from a ruptured aneurysm? How do you help them feel comfortable with there's this aneurysm in their head? So it's about how you, one, provide them the reassurance with the delivery that you give. How do you explain it? How do you tell them that this is what's going on? But although we don't know the potential, the likelihood of risk, here's where you stand. Here's where you are. That reassurance, putting them at ease, encouraging them about living their life so they're not walking around with this doom and gloom sensation. That is what your responsibility as a doctor is. Making sure that you say it in a way that they're able to just live their life. Also plugging them into the proper resources, helping them to connect with people and resources that can walk them through this. If they have had family members who have been, who've had aneurysms, or friends, if they don't know anybody, this is an opportunity to make sure that they're in the right support groups and have the right awareness. Letting them know that they can live their best life no matter what. Showing them examples of people who we know are strong people who are living and doing and being prosperous. These are the examples that we want to allow them to see, that survivorship is real, that living with this condition is something that does not have to be the end of them, unless they go crazy and burn a whole city, and then they have to be killed by Jon Snow, and it's over. So, any questions? Thank you. Oh, go ahead.
First of all, Dr. Johnson, Faye.
Boy, like joy.
Sorry, I said John. First of all, thank you very much for the excellent overview and presentation. I really enjoyed it. You mentioned one of the scoring system that our colleagues use, the phases. There's another that recently was published called UIA. And some of the colleagues who are sitting here, they are authors on the paper. So it's really a famous paper that the FDA uses. Now, the problem is with the demographic shift that we are getting older and older. And you mentioned 70. I feel a little bit worried, but anyway, so the point I wanted to make is, since our life expectancy moving towards 100, and there was paper coming out of China that show the older you get, the likelihood of rupture, it goes up. That's
Yes.
one thing, even if the aneurysms are small. The second thing is, once you rupture and you are older than 80 or 90, the outcomes are bad. And they found also out when you do endovascular therapy, this minimal invasive that Ricardo and his colleagues do here, that the outcomes are better. So when you see today a patient who is 70, has a 3 millimeter aneurysm, what do you tell to the patient? If the patient is not nervous, or a patient who is super nervous, and every time he has a headache, he thinks something is going to blow in his head.
What do I tell him? One, I make sure that I keep close touch on him. It's one of those things. The fortunate thing about primary care is I can see them every week if I need to. I can see them as often as I need to. I make sure that they're connected with the great neurosurgeons who I trust to take care of my mom or take care of any other patients. But I let them know to live their life, to make sure, because if they've made it to 80s and 90s already, then they've been living a pretty good and prosperous life. So I tell them to keep living, and that there are things that are available that may ultimately decrease their risk, or that things we can do, but I tell them to keep living, and so that they can have the best life that they can. Go ahead.
One of the comments I wanted to make is actually tomorrow we'll talk about some tools that allow us to check using artificial intelligence if the aneurysm is changing over time. So like it's interesting that you mentioned the follow-up, how to do those images. Obviously, I think what we're trying to talk about today is like how do you counsel somebody that has an aneurysm? But part of giving peace of mind may be that we do have ways to treat minimally invasive, but at the same time, we also have better ways to monitor the aneurysms too, and have the ability to detect if there's a change in aneurysm shape or size. And I think that is really also a really important part of it. Smoking, high blood pressure, you know, and emphasizing those things, it's something we do quite often too. And I think that this is, I think tomorrow we'll be able to go over and show exactly how we're doing this in practice today too.
Good. I'm looking forward to that. And as any modifiable risk factors, I'm always going to encourage that we talk to them about, and that we make sure that they are able to focus in on those things, and that we keep the blood pressure controlled, that we definitely make sure that they're not smoking if they're smokers. But again, more importantly, getting in and making sure that we're staying on top of it. The imaging is done, the follow-up is done. Those are the things. So I'm glad that we have this availability of mechanisms to make sure we're following appropriately. Dr. Hanna.
Thank you. Always very educational and inspiring. Not every single, with all the respect to the others, not every single primary care physician has the same knowledge and into brain aneurysms like you do, Sacula. My question to you is, I go to my primary care physician, I'm going to be asked prostate cancer in the family, colon cancer in the family. You talk about guidelines that is very generic. If you read the guidelines from American Heart for screening, is very soft, so soft that if any new patient come to a Baptist or any other hospital, there's no there in screening, do you have any brain aneurysms in the family? So trying to raise awareness, we got funded by the state of Florida, and we're screening anybody that has first-degree relatives, just to show what is the scoop of that picture on Florida, South Georgia. But why we don't ask our patients that go see a primary care physician, fibromuscular dysplasia, if this lady has fibromuscular dysplasia, it's 4X, and these people are not getting screened. If you have 2 family members with brain aneurysms, these people are not get screened. Why at Baptist we don't put a little task force and change our screening on new lovely Epic, why we don't have brain aneurysm in the family, yes or no? That would spark a conversation with the primary care physician to ask, who had an aneurysm? Oh, my great grandpa. Okay, you don't have to worry about that. My mom died and my sister had one. So what would take is that American Heart Guidelines is stronger endorsement. From your perspective, what it would take to get this screening question on every single primary care provider in the country?
So for every single provider in the country, I think one of the things that we just have to do better in general is take a good family history in general about it all. It is literally the biggest fight that I have with my staff. They leave it blank for everything, whether it's diabetes, high blood pressure, cancers, or definitely aneurysms. So really starting with retraining from the basics of asking real family history questions is going to be one of those things. If we just do that part right, that's the start. Now, when you talk about guidelines, it has to be something that usually is going to be passed down. The United States Preventative Service Task Force has to say, hey, this is important, so do it. The CDC has to say it's important. Some body, the American Neurological, we need to make this a more generalized screening. And if that is the case, then I think you'll see a broader representation of it. For me, as a primary care doctor, I just want a good family history no matter what. And so I do ask them those questions, and I pound in my staff, ask the questions, ask the questions, ask the questions. So if we can have generalized at Baptist, what we could do, I'm looking at Mr. Zuino, what we can do is make sure that we're training MAs in a way, because they're doing the triage, they're doing the uptake, making sure that they're trained in a way to understand the importance of family history. They do not completely get it. And it's because there's so many things that they're thinking about and worrying about and making sure they're checking every box in Epic. But family history is extremely important. And when I say this is a daily fight with my staff, it is something that I have worked really hard to make sure they do better. And so we have Liz Collins in place who can say, train these people this way so that they're doing the right screenings, so that we may catch these people for our great our neurosurgery department, so they'll have some more people to take care of.
Thank you.
You're welcome.
Any more questions?
Any other
guys?
questions? I was trying to be brief, so.
No, it was perfect. Thank you very
All
much,
right,
as
thank
usual.
you.
Thank you.